He is going to be presenting a project today that he had worked on with Dr. Srivastava, looking at 7 Tesla MRI in imaging the optic apparatus in the context of pituitary adenomas. He's won a number of grants to support the various research projects that he's worked on, and we're looking forward to hearing his presentation today.
All right, good morning. I will share my screen. All right, can you see that screen?
Yes, looks good.
Great. Good morning. My name is Jack Rutland. I'm a 4th-year medical student here at Mount Sinai. And this morning I'll be speaking about research that I've been involved with really throughout the entirety of my medical school education with Dr. Srivastava. And I have no conflicts of interest. So despite advances in modern day endoscopic and transnasal surgery, patients with pituitary adenoma continue to suffer from vision loss, which may or may not recover following surgery. And the visual system is composed of various neural structures. However, very little is known about what, if any, changes occur to structures in the optic apparatus that are posterior to the chiasm, such as the optic tracts and radiations, the lateral geniculate nuclei, and the primary visual cortex. And current clinical approaches to characterizing vision loss in these patients include neuro-ophthalmology, which include optical coherence tomography and Humphrey perimetry field testing. And while OCT provides evidence of retrograde degeneration to the retinal ganglion cells in the retina, very little is known about a similar anterior grade degeneration in the posterior structures that may or may not contribute to the overall clinical picture of vision loss in these patients. Similarly, conventional MRI, which is traditionally done with 1.5 or 3 Tesla, is used to diagnose and to characterize pituitary tumors. And it's used to essentially assess the relationship between the tumor and the optic nerves and chiasm. But it's, again, not useful for assessing posterior structures, which haven't historically been thought to be involved in these pathologies. And it's also not traditionally used to probe microstructure of different optic structures. So here at Mount Sinai, we have the Biomedical Engineering and Imaging Institute, which is one of the first 70 research centers in the country. And we've been recruiting patients with various skull-based pathologies for the last 5 or 6 years for quantitative and qualitative analysis. And the data that I'll be presenting today comes from Dr. Srivastava's IRB-approved skull-based 7T imaging study, where all patients underwent 7 Tesla imaging with secondary analyses and post-processing techniques such as DTI tractography. And for the purposes of this talk, we will only be speaking about patients with pituitary adenoma, although we have expanded our scope to other skull-based pathologies. And as you can see in that bottom left panel, the benefits of 7 Tesla MRI include increased signal to noise ratio, which can be parlayed into enhanced contrast and increased spatial resolution as compared with 1.5 and 3 Tesla. So the primary objective of this study was essentially to perform a multimodal and comprehensive characterization of the visual system in patients with pituitary adenoma. And in order to do this, we broke this main aim into 3 smaller objectives, which were examination of microstructural integrity of the white matter tracts, being the optic tracts and optic radiations, to assess the structural changes that occur in the lateral geniculate nuclei in these patients, and also to perform a retinotopic analysis of the primary visual cortex. And these studies build on existing basic neuroscience research that have demonstrated anterior grade and retrograde degeneration in the visual pathway that result from neuronal injury. However, these processes have not yet been studied in the context of chiasmal compression by pituitary adenoma. With regard to our first objective, which was to interrogate the critical white matter structures in the optic apparatus, the optic tracts and the optic radiations. In order to do this, we performed diffusion-weighted imaging tractography to isolate these two main fiber bundles. To isolate the optic tracts, we drew ROIs on the optic chiasm, as you can see in the top two images. And then our posterior seeds that we used were the lateral geniculate nuclei, which you can resolve on 7 Tesla, given the increased spatial resolution and enhanced contrast. You can see the outline of the LGN in the bottom left image. We'll see better images of these in future slides. And then to isolate the optic radiations, we used the LGN as the anterior seeds, and we used a semi-automated cortical brain segmentation algorithm in order to segment the primary visual cortex as our posterior seed for the radiations. And we performed this analysis in 18 patients and 16 healthy controls. These are images of the reconstructed tracts. You can see in the top three figures, different views of the optic tracts that we were able to reconstruct with tractography, and in the bottom, the optic radiations. And then on the far right, you can see a 3D rendering, which we think gives a pretty nice view of the entire apparatus. And these were just parameters that were previously published that we used to isolate these tracts. After tractography was performed, we sampled 20 equivalent points along both the optic tracts and radiations to give a normalized spatial overview of what was happening as you moved from chiasm to lateral geniculate nuclei and from lateral geniculate nuclei to primary visual cortex. So as you can see in these graphs, patients are in the blue and the controls are in blue, patients are in red. There was a bilateral reduction in fractional anisotropy in the optic tracts by nearly 22% and the optic radiations by nearly 18% in patients with adenoma compared with controls. And fractional anisotropy is essentially a measure of directionality of molecular water molecules with decreasing values representing damage to the white matter fibers due to decreased white matter integrity. And then in the bottom panel, you can see we found that mean diffusivity, which is a different microstructural diffusion indice, was increased bilaterally in patients with pituitary adenoma by 18% in the optic radiations. And in contrast to fractional anisotropy, mean diffusivity is typically expected to increase in the presence of white matter damage, given that it reflects the overall mobility of water molecules. So in the presence of certain pathologies, you'll see increased mean diffusivity as opposed to decreased fractional anisotropy. We also sought to correlate our diffusion indices with functional status in these patients using neuro-ophthalmology. We found significant positive correlations between FA in the optic tracts and mean deviation, and negative correlations with pattern standard deviation. And the reason that we found a negative correlation with mean deviation and a positive correlation with mean deviation and a negative with pattern standard deviation is that mean deviation gets more negative as the field worsens, and the typical values are between 0 and -2 decibels. So as those values increase, you actually expect the FA to also increase. So that checks out in terms of what we would expect to see between imaging and functional results. We also found a significant positive correlation between tumor volume and pattern standard deviation, which you would expect given tumor burden on the chiasm and worsening visual fields. And these results were published in the Journal of Neurosurgery. With regard to our second objective to assess changes that occur in the lateral geniculate nucleus, we performed a separate analysis. And as you can see in this left figure, this was from a few slides back from our initial study. And when we were performing these segmentations and isolating the LGN to perform the tractography, it was noted incidentally by our neuroradiology collaborators that the LGN in patients with pituitary adenomas tended to be smaller and more irregular compared to healthy controls and somewhat harder to harder to delineate. You can see the zoomed in image on the right of the left LGN on the top is in a healthy control. You can see that white arrowhead is pointing to the LGN compared to that bottom panel, the bottom right image, which is a patient with significant chiasmal compression, which just on kind of qualitative analysis is smaller and slightly harder to delineate. So this prompted this follow-up analysis in which we wanted to quantify if there was any alterations in these lateral geniculate nuclei in patients with pituitary adenoma. In order to do this, we used 3 independent blinded readers to measure the cross-sectional area on 70 images on the slice of greatest, the greatest profile of the LGN. And we did this in 27 patients and 27 age and gender match controls. So you can see here, these are our initial results. All 3 readers showed significant reductions in cross-sectional area of the lateral geniculate nuclei in patients with adenoma compared to controls. And you can see on the far right, the composite score of the 3 readers with an average score of 13.8 square millimeters compared to 19.2 in patients. So we think that this reflected a real reduction in LGN surface area in patients with pituitary adenoma. And interestingly, we also did a sub-analysis where we looked at patients who had subjective postoperative vision improvement after decompression of the chiasm, and patients who had no subjective postoperative vision improvement. And the patients who experienced the postoperative vision improvement had lateral geniculate nuclei that were about 40% greater in cross-sectional area than their counterparts that did not experience improvement after surgery, which lends itself to possibly being a positive prognostic biomarker, which may explain some of the variability in vision improvement in these patients. We also sought to assess the degree of tumor burden on the lateral geniculate nucleus. In order to do this, we did 2 analyses. The first was to measure chiasmal deflection, which was measured by our neuroradiologist collaborator. You can see there was a significant negative correlation between deflection of the chiasm and lateral geniculate nucleus surface area. This was observed in both patients and controls, although you can see in this graph, controls had essentially no chiasmal deflection given that there was no tumor. Similarly, we observed a positive correlation between chiasmal thickness and lateral geniculate nucleus surface area, likely given that larger tumors cause the chiasm to become more splayed and thinned out, which would be reflected in a further reduction in lateral geniculate nucleus surface area. And lastly, we sought to correlate these LGN surface areas with results from neuro-ophthalmology. We found a positive correlation between mean deviation and LGN surface area. Again, as mean deviation approaches 0 decibels, the visual field is expected to become more normal, and lateral geniculate nucleus size, we found increases in response. And then we found an opposite effect with pattern standard deviation in lateral geniculate nucleus surface area. Again, as pattern standard deviation becomes a greater value, it reflects a more irregular field, and lateral geniculate nucleus surface area decreased in response. And finally, we found a positive correlation between retinal nerve fiber layer as measured by OCT and the lateral geniculate nucleus surface area. And this is a schematic that was illustrated by Jill Gregory, who we work with here at Mount Sinai, reflecting what we found in this paper and what we believe is happening in these patients with significant compression of the optic chiasm and subsequent anterior grade degeneration of the lateral geniculate nucleus. And these results were also published in JNS. And lastly, with regard to our third objective, we sought to examine the what, if any, response in the primary visual cortex as a result of chiasmal compression. This study was really prompted by prior prior studies at lower field strengths that showed inconsistent results with regard to thinning of the primary visual cortex in the presence of compressive pathology. We thought that these inconsistent findings were partly because they were done at lower field strength, 1.5 and 3 Tesla, which results in more volume averaging and lower spatial resolution. And also, we found that we believe that primary visual cortex thinning may be a localized process as opposed to a global thinning of the entire primary visual cortex, given the retinotopic arrangement of the primary visual cortex. So we hypothesized that some of these effects may be diluted by simply analyzing the entire thickness of the primary visual cortex. So we aim to reconcile these disparate results by performing a retinotopic analysis of the primary visual cortex using 7 Tesla structural MRI. In order to do this, we looked at 8 patients with significant optic chiasm compression, as well as 8 age and gender matched controls. They all underwent high resolution structural imaging, and we used an automated whole brain segmentation method to calculate and segment the primary visual cortex. And in order to account for natural variation in cortical thickness between individuals, a normalized thickness ratio was calculated by dividing the thickness of the patient's primary visual cortex with their matched control at every point in the retinotopic arrangement. We calculated polar angle and eccentricity coordinates of the primary visual cortex using a previously published algorithm by Benson et al., who was a co-author on this study. Polar angle and eccentricity maps were overlaid onto cortical thickness segmentations from our automated segmentation method, enabling extraction of cortical thickness corresponding with their exact polar angle and eccentricity coordinate pairs. You can see in the image on the screen, the top right figure shows whole brain cortical thickness, and then the bottom left shows polar angle, and the bottom right shows eccentricity, which were used to map back onto the cortical thickness maps. These are just results from the Humphrey perimetry for one patient, showing this workflow of how we mapped points in the visual field onto the Humphrey perimetry field using polar angle and eccentricity measurements. And these were some of our results. You can see here that we did not find any significant global changes in the primary visual cortex thickness. This is somewhat unsurprising given that we had 8 patients, essentially 8 data points compared to 8 data points in the controls. However, when looking at the correlation within each of these 8 patients, we found that there were significant positive correlations between the deviation values in the Humphrey perimetry field testing and the cortical thickness ratio. And from that, we were actually able to calculate an equation to predict results from the Humphrey perimetry field testing using cortical thickness. These are those 8 patients showing the positive correlations. You have the cortical thickness ratio on the x-axis and the deviation in the visual field on the y-axis. And you can see that as cortical thickness increases, the deviation values increase as well. We think that there are 2 possible mechanisms for this finding. The first would be further evidence of anterograde transsynaptic degeneration due to chiasm compression, which is in line with the previous 2 studies observing degeneration of the optic tracts and radiations, as well as the lateral geniculate nucleus. There is another hypothesis that has been proposed by some groups, being reduced blood flow due to reduced metabolic demand in certain areas of the primary visual cortex that correspond with visual field loss, contributes to neuronal fallout and localized volume loss. And subsequent studies looking at perfusion of these areas using arterial spin labeling or other perfusion imaging techniques would be interesting in order to determine the exact mechanism of localized volume loss in the primary visual cortex. With regard to future directions, one thing that our current protocol does not include is postoperative 7 Tesla MRI. which we think would be very useful and interesting in for determining what, if any, recovery occurs to these critical optic structures after decompression of the chiasm. We also aim to correlate these imaging findings with long-term neuro-ophthalmology, which will help better determine how useful this imaging modality is for long-term prognostication of patients with vision loss. And we have also recently received funding for a similar study in vestibular schwannoma, studying hearing loss and the critical structures in the auditory system, such as brainstem nuclei, the medial geniculate nucleus, the auditory radiations, and Heschel's gyrus, which is currently underway and that we're currently recruiting patients for. And then lastly, I came across this clinical trial, which I found really fascinating, and this is being done at Rush and University of Chicago and a couple other centers, but they are essentially trialing an intracortical visual prostheses for patients with acquired blindness. And I think the results from our last study where we mapped visual field findings onto the primary visual cortex using 7 Tesla MRI may be relevant as more of these studies and cortical prostheses become more prevalent in neurosurgery in terms of correlating actual functional results with exact areas in the primary visual cortex. So I thought I would include that as well. And with that, I would like to thank my mentors and collaborators on this study, of which there are many, the Department of Neurosurgery for letting me speak this morning and for letting me complete my sub-I, and the other various departments at Mount Sinai who helped contribute to this body of work. And these are my funding sources. And I'm happy to take any questions if there are any.
Thank you, Jack. I'm just going to make some comments before we do questions. So first of all, for those of you who don't know Jack's been really integral to the research that I've been doing and that several of our medical students have been doing over the last 4 years. I first met Jack when he was actually working in the 7T research group before med school even. And then so from before med school all the way through, Jack's consistently done, as you can see, high quality research. The actual planning and execution of these studies, as you can see, is quite complex, and Jack's really been really not only integral in terms of the study design, but in the data analysis and devising the next study. And I just want to take a step back. You know, when we first started doing 7T work, the initial thought was we were going to see interesting aspects of tumor anatomy. And I think we do for sure see that. But what's been most fascinating, in my opinion, are these complex anatomic and physiologic changes that we're seeing that tumors do. Like Jack said, we haven't really even started the molecular kind of metabolic analysis. But if you look purely from a structural anatomic analysis of the brain, and 7T gives you and facilitates that ability, you start to see real changes that are occurring real time in our patients who have this type of tumor. And I believe that the white matter tracks, and looking specifically at tractography, and I'll call it tractography, is really what's going to provide us with quantitative measurements of how tumors affect various physiologic systems in the brain. And can we develop prognostic ways of grading and even get an idea of outcome? And I think this is the beginning of where I believe 7 Tesla imaging is really going to have impact, is in these more intricate analysis of brain structural anatomy. So again, really nice work, Jack.
Thank you, Dr. Srivastava.
Jack, can I ask you, do you know how long these scans are?
The research protocol, they're a research protocol and they are 90 minutes long. So they're definitely on the longer side, but that's also because we include things like fMRI in some cases, diffusion weighted imaging, and some other more novel sequences.
Hey, Jack, nice job. You know, as we see the kind of growth of MR imaging techniques, it seems that the lower Tesla units are able to kind of do what the higher Tesla units are doing the more as time goes by. And I'm wondering, you know, I also love 7T, and, you know, I think for brain tumors is quite helpful. But the question is, you know, is a lot of this stuff going to be able to be done with 3T, with sequence modifications and other types of innovations with lower Tesla MRI scanners?
Yeah, that's a very common comment that we get for all of our papers is 7 Tesla really necessary? I know that there's some really interesting work on the machine learning aspect using 7 Tesla data sets and then correlating them back to lower field strengths to kind of inform them using the higher resolution and increased signal to noise data that's encoded in the 7 Tesla imaging. So I wouldn't be surprised. I do think that 7 Tesla has a lot to offer in terms of these different intracranial pathologies, but I think that in the future, given that it's still a relatively rare modality that a lot of centers don't have access to, we may see more of these machine learning approaches to essentially guide to couple the 7T and 3T data so that you can get similar findings using lower field MRI.
Yeah, Costas, I can also help answer that. So I think you're absolutely right that I think there's going to be some aspects that are transferable from 7T to 3T. Remember, 3Ts I wouldn't call a low field. 3T is still a high field. It's not quite like a 0.8 or 1 Tesla. But what I think 7T is going to, and this is still, I believe, the beginning, is that leveraging the signal to noise ratio and specifically looking at diffusion tractography is really where I believe the advantages of 7T is going to start to really blossom. And I think that's where a lot more analysis is needed. I also think that we haven't even opened the metabolic analysis yet. And I think that's really where we're going to start to see some more structural metabolic changes, which we really haven't done any of these studies yet.
Jack, it's wonderful work, very sophisticated. I like the relentless logic that brings you from one step to the next. So what do you think is the explanation for why an area of cortex that is at least 1 synapse away from the area of compression would decrease in thickness? How does that happen?
That's a great question. I think the 2 mechanisms that I proposed, I think are, very strong mechanisms. Anterior grade transsynaptic degeneration has been well described in the basic science, neuroscience literature. There are some animal studies that show retrograde degeneration, essentially I think they used rabbits, and they knocked out the occipital cortex using essentially mechanical force, and they found degeneration using OCT in the retinal nerve fiber layer. So we know that it occurs in both directions, both anterior grade and retrograde. So in that sense, this work really is not showing anything super new, but it is the first time it's being proposed in vivo in patients with chiasmal compression by pituitary adenoma. I think it's also possible that, the other mechanism that I was reading about, that certain areas in the visual field, given that they're not being used and that the corresponding cortical parcel may have less of a metabolic demand given the visual field loss, could result in a decrease in blood flow and decrease in metabolic activity, which results in neuronal fallout. I think that's also a very valid mechanism. However, our previous work is more in line with the first, which is an anterior grade transsynaptic degeneration. Even though there's an insult that is more than 1 neuron away, we know that it can be transmitted, and we think that that's essentially manifesting in changes in the primary visual cortex.
Great, really great work.
I just want to say, sorry, one more comment on that. So I think some of the mechanisms that we've learned from stroke patients. And just like as Jack was saying, when you look at patients who've had stroke, particularly stroke in which they've had visual loss, it really does seem to be a blood flow related issue in terms of, again, change to cortical structure. And I think it is hard to postulate something as complex as vision, which is so multisynaptic in terms of having a direct, almost 1-to-1 correlation. So probably the truth is somewhere in between in both of these pathways. So I think it's fascinating because it's real life neuroplasticity. So good work, Jack.